a number of cards. So I hope I'll get to yours. I may not get to yours exactly in the form in which you wrote it. So, and then I want to add a third one, and then I'll get to the cards. So the first question is going to be on this issue of soothing the patient. What does that mean? This whole issue of should there be physical contact between patients and therapists. The second one is how to deal with, or how do you respond to repeated self-destructive behavior and or a serious suicide attempt. And the third one, I'd like everybody to elaborate a little bit more on the aspect of parenting or the interplay between the infant and what equipment the infant does, or what capacities with respect to emotion regulation the infant does or doesn't have, given that they're a unique individual, and then the parental response to that, which gets into issues of reparenting. It gets into issues of rage and transference-focused psychotherapy, and also gets into issues of invalidation. But I'd like to start off with the issue that Jeff made my life easy when he said, so that if a patient is, and I hope I'm not distorting it, distressed enough and upset, and the therapist is saying, is it okay if I put my arm around you? I don't mean to distort what he said, but how each one of them might respond to or think about in the context of their theory when it's clear that the patient wants and or needs more direct emotional comforting than what the words at least might imply, or words may not seem to be enough, or the patient is at least expressing that words aren't doing enough. How's that for a start? All right.
So let's see. So just one at a time. Right now we're talking about the giving a patient a hug or something like that. You know, in DBT, there are a couple of issues that we would need to consider. There's no should or should not around the behavior of physical contact, holding a hand or giving a hug. The question is, under what circumstances and for what purpose? Clearly, let me just say what would be clear. We would never give a hug because it satisfied the therapist, okay? That ever, under any circumstances. I'm sure that we could agree on that one. But also, the timing and the situation. I think in DBT, our idea would be to provide some sort of soothing when, and only when, the patient is actually also doing things that are self-managing. So not instead of the person managing her or himself, but in addition to. So this is a kind of contingent thing. So if a client were actually experiencing a primary emotion in our language and feeling very sad, for example, and managing that quite well and doing, in fact, the accurate expression of being sad and feeling sad and expressing sadness, and asked for somebody to hold their hand or to give them a hug on the way out of the session or something like that, we very well might. Again, if it were within also the comfort range of the therapist. There are also obvious clinical issues there, like what does it mean for the patient? What does it mean? Could this be taken as a sexual act? We would never do it in those circumstances. So it's possible, and it would never be taken lightly. Having said that, I mean, this is not, there's also gender to take into account and sexual orientation to take into account and the match between the therapist and the client. So it's not something I think to be taken lightly. At the same time, it's not something in DBT we would rule out. But it wouldn't be something you'd see very often either in DBT, I'd have to say. There might be occasions, but it would be really around soothing when the person is specifically already doing something that's quite healthy and the person's already empowered, so it's not disempowering to them and couldn't be misconstrued as something that's dysfunctional.
I can start off being a little more direct, but then link it up to our theory. TFP therapy would not hug or hold a patient. But let me link it immediately to the theory, which actually fits in with a lot of the other kind of clinical examples we've been discussing this morning. If you look at our theory and the idea that borderline patients are dealing with internal representations that they believe in, and one of those internal representations is the other person, the provider, who can do everything for them, who is ideal. In our experience, no matter, at least with a certain type of patient, we might get back into subtypes, the best favor we can do for somebody is to get them to a more realistic position. We find that a lot of therapists with very good intentions wind up falling into traps. It might be hugging the patient, which would be felt perhaps to be enough to reassure the patient that you do care about them, you don't want to reject them, which they assume. It might be taking phone calls or having sessions when you're on the vacations. But in my experience, a very large number of my patients come from therapists who did these things, and it led down a road to more and more acting out. I think for two reasons. One is that it's very gratifying to have this kind of response from a therapist, a hug, a session when you know the therapist is on vacation. So if the way to get those gratifying responses is to continue to act out and be ill, that's what we call secondary gain, and we try to minimize that. But the real thrust of the problem, in our view, is how strong these internal images are. And again, maybe we're dealing with different subtypes of population of patients. But let me just give you one clinical example about how I tried to do something out of the frame, but you'll see what happened. One of my patients, like all of our patients, said, it's horrible when you go away. I can't picture you. It's like you fall off the face of the earth. Every time you go away, I assume your plane is going to blow up the minute it leaves Kennedy, which, of course, is a fantasy I'll look at later for the aggressive component. Because, seriously, I feel that the reason the person can't picture me is because their anger at me going away destroys the positive image they have of me. So in any case, one of these patients said, look, it's so horrible. I don't know where you are. I don't know if you've arrived safely. So I said, look, okay, this time I'm going to Spain, and, let's do an experiment. You say it'll help you if I call you from Spain. Arrived at Spain, called the patient. She was very surprised and delighted at the moment and said, thank you so much. I get back to New York 10 days later. She walks into her session looking daggers at me and furious. She said, I'm furious at you. And I said, well, why are you furious at me? She said, you lied to me. I said, I did? What was my lie? She said, you said you were in Spain. Nobody would ever care about me enough to call me from Spain, so you were probably on Long Island. I'm quoting. So in my mind, you can try and try and try to provide the good object, to be the parent they may not have had, but unless you really explore the depth of their negative internal image, I don't think you're ever going to do it. And since this is an occasion to talk about a comparison, let me just add a word about the study that Jeff mentioned, because since we're all...
There is a question.
Oh, there is a question? Okay.
Around the dropout
Okay,
rate. So
but all right.
So
dropout rate. That's a perfect way to put that in.
Let's hope, okay?
Okay.
And I guess,
That's well, I was just going to say, I think especially with the physical contact, there's such a slippery slope. We all know therapists or have heard of therapists who've got into trouble by offering something that was innocent at first, but since the person involved usually needs more and more and more reassurance, it can get really messy. And I know cases where patients' lives have been destroyed, and therapists' lives too, by things going too far.
All right. Well, I guess starting with what Alan said first, because I don't think that our point of view is so much different from Alan's in one respect, that we do think you have to be extremely careful who you do it with, under what under what circumstances, taking into account, is it something the patient really wants? Is it being interpreted sexually by the patient or as a sign of caring? So I think that all of those warnings are very appropriate, and we teach our therapists under what conditions it's okay to hold, how to hold, what type of holding is inappropriate. So it's very specific in terms of the idea of certain conditions under which you hold. However, it's sort of, one other comment Alan made, though, is that it could be disempowering for the patient to be held. And I think this is where we clearly would part company, because our view is, again, that a borderline patient is functioning emotionally at the level of a 2 or 3-year-old child. The fact that you won't hold them when they cry and cry and cry and can't stop from crying is not experienced by either an older patient or a young child as disempowering. It would be like telling a parent, don't hold your child when they're really crying because you're disempowering them. And I just don't believe that's true. But it has to do with whether you view the borderline patient emotionally as an adult or emotionally as a child. I say that borderline patients are intellectually, obviously, adults, but as emotionally, particularly early in treatment, they're functioning at the level of a young child, and they need the same things a young child needs. And therefore, we feel that the holding is, it's not essential to the therapy, but when there's no other way to reach a client who is really sad, really depressed, really feeling abandoned, can't connect to you, touch is sometimes the only way to do it. So I say, yes, you have to be very careful how and when you do it. But on the other hand, the value of it with clients who need it is incredible, and it's one of the most powerful things we can do for some clients. Now, just one quick thing.
Can I respond to that
sure,
part first?
yeah.
Because I think that this is a big difference between the two treatments. Because in DBT, I'm sure, I'll speak for myself, obviously not for Marshall Linehan, but for myself, and I think that the treatment would say this, is that I think that we would not want to view people as children who are adults, and would find it very patronizing to see a person as emotionally a child. I think the idea is, and then in fact we would argue, I think, that if you treat a person as a child and respond as a parent of a child, you're likely to reinforce a lot of childlike behaviors. And actually, in DBT, I would expect the person and help the person respond in emotionally more sophisticated ways. And not even think about it as child versus adult, but as skilled or less skilled. I mean, there are lots of things we as adults learned how to do, and lots of things we didn't. We don't say because we didn't know how to do it, we didn't learn that particular thing, that we're a child in that way. We're an adult without that skill. So I think it's a fundamental thing, because I think that there are implications for that in terms of, like, a lot of the things ways that you talk about your schemas that are just very different in DBT. I would worry that would reinforce the person's, for example, saying stuck in a secondary emotion by potentially providing a lot of nurturance at the wrong moment. I would be inclined, just to give you an example of how different this might be, if a person were really stuck in a secondary emotion, I'd be more inclined to kick them than to hug them. And I'm quite serious. I've done this. I've kicked my patients a lot more than I've hugged them.
What's give me an example of a
kicking,
secondary
I have
emotion.
to show. Can I use you, Ken, as an example? This is not as bad as it sounds. But so Ken is stuck in another emotion and is not managing at all.
What's the emotion?
Whatever.
Give an example of a secondary emotion.
If he's dysregulated, by definition, he's into a secondary emotion.
Okay.
By definition, even if he starts sad and he's overwhelmed with sadness now, he's now got not just ordinary primary sadness. I might go something like this. That's the kick, okay? Notice how he looked. He couldn't not look at me. It broke through, okay? Now, I don't think anybody would consider that abusive, and heavens, don't sue me for this, okay? But the idea is that I'm here and I'm paying attention, and what you're doing, and then I would coach. I would say, okay, Ken, you need to look at me. Whatever you're paying attention to in your head is actually getting you stuck. Look at me. Let's focus. Let's use some skills. And I would coach him back to his primary emotion, and then I might, if it were Ken, and I know Ken, and he's a male, and I might pat him on the shoulder and say, okay, I might at that point. Probably not, but I could. Certainly at that moment after he's managing. But my concern is that he's in the middle of this mess, and then I provide a lot of comfort. What I'm saying is, the more of a mess you are, the more support I give you. And I think that's a very wrong message to give anybody, including somebody who's a client. That's a big difference.
Well, it is an enormous difference, and I guess it's interesting, the idea of calling a secondary emotion when a client is too upset, when they're crying too much.
Well, it's
I mean,
dysregulated at the very
yeah,
least. They're
well,
not
but we
managing.
don't see that as something you want to take someone and get them out of it. Then that gets to the fundamental issue is, are we trying to make deep personality change, or are we just trying to change outward behavior?
Well,
If your
that's a
goal
false-
is,
that's a false
let me finish,
dichotomy,
please.
yeah.
Let me finish. Yeah, okay. And I'm just saying that if your goal is to get the patient to stop crying too much, and that's your primary goal, and to engage in other skills like an adult would, and get them to act like an adult, I think DBT is great at that. But in deep personality change, you have a patient who feels emotionally like a child, and you can teach her all the behavioral skills in the world, and at the end of the DBT treatment, she still feels miserable because that pain is still there. You haven't even dealt with the pain. In fact, you've tried to cut off the pain and get her out of it by giving her a little kick. So I would just say we have a completely opposite view, which is that when someone's experiencing the deep pain, we want them to go more deeply into the pain, stay with the pain, and we nurture them like you would with a child. If a child is crying and crying and crying, the goal isn't to say, stop crying and give them a little kick. What you do is you put your arm around them and you say, look, I'm really sorry. I don't know what's upsetting you right now. Yeah. Go ahead. Yeah.
Maybe I did my job too well.
Your wish came true.
Let me see. I want to go on to the second one, and then the third, and then see if we can get back here, because there's a number of questions that I think approach this on a broader level, which is, what is the role of intellectual understanding in schema-focused therapy and in DBT, and then what's the role of behavioral modification in TFT? So you're beginning to move into another question. And obviously, we could be here at 3 o'clock. So I want to use my prerogative to move on to the next one, and I'm sure it will come up again. So that you have a patient who's telling you that she's cutting in between your sessions. Where do you go from there?
Well, since I've been quiet for a minute, first of all, your wish came true. I think differences are emerging. I'm going to pick up on the idea. I'm going to link it to your next question, but I think this debate between Jeff and Alan about, do you stick with the pain or do you not stick with the pain? I'm not sure if Alan would agree with Jeff's characterization of DBT, but I want to say how TFP would work with that. Then I'll link it to your thing. Because we also want to stick with the deep pain. We want to get to the deepest, most intense affect. But I think where we differ, we don't want to then sort of provide what we would consider a superficial reassurance, but we want to see how the patient contributes to creating that pain in themselves. Because one of Otto Kernberg's simple but profound statements, I think, is every emotion is the reflection and manifestation of an internalized relationship. So if the person is in pain, it's how they're experiencing the relationship with you, but we want to show them what in them is contributing to taking a relationship that is, by definition, helpful and supportive, and experiencing it in a different way that we think is determined by the perception they add to it. So how would we deal with a patient who comes to a session having cut him or herself, having gone to the ER and having been discharged from the ER?
Let's just do that they're telling you that they're cutting in between the sessions.
Okay. They're cutting.
Whether they're going to ER or not.
Okay.
They're telling you about that behavior.
Okay. Now this gets to your question about how we use some what might be considered behavioral techniques, because as I said briefly in my talk, the first phase of TSP is setting the frame of treatment, and the frame of treatment involves what responsibilities the patient has and what responsibilities the therapist have toward the treatment. As soon as some BPD patients hear this, they say, you're crazy, you don't know anything about BPD, I thought you were a specialist, I can't have any responsibilities, by definition I can't control my actions. We see the person, as Alan said, as an adult and a child, and we think a lot of discredit is given the BPD patients by not assuming they have some control if they stop and try and muster it up. So long story short, we say, look, there are a whole array of treatments possible. This treatment is based on trying to get at the depth of your soul, understand what troubles you at the deepest levels. To do that, we need a relative amount of calm, because we have two choices. We can either help you understand things in depth, or we can run around putting out fires that you start. If we run around putting out fires you start, then it's something that doesn't really lead anywhere except maybe, keeping you alive or from hurting yourself, but we think you can do better than that. So part of the frame of treatment is that the person make the most honest commitment they can to giving up the acting out behaviors with the understanding that those will re-emerge from time to time. So a patient comes in having cut him or herself, we say, what's going on? Something happened, and this is against the initial agreement we had. So the first thing would be, what were you feeling? The second thing would be, what were you trying to tell me? You're trying to tell me I'm not giving you enough. You're trying to tell me you're angry at me. Or you're trying to tell me that there's something here that I'm not seeing. Are you communicating something you can't say in sessions through actions? Are you keeping something to yourself because this was an action you did to yourself, keeping me out of it? What we would not do is encourage phone calls about this problem between sessions. That's different from the two other models. We encourage patients, if they're having an emergency, to seek emergency help. We explain that there are different parts to the healthcare system, the ongoing therapy and the emergency services. We can't do both. And we do have a strong belief that if we respond by providing more contact to acting out, we foster the acting out. That's behavioral. It's a behavioral concept. You reward a symptom, the symptom just continues. So our emphasis would be, what's going on? What were you feeling that you can't express? What were you trying to communicate to me that you can't put into words? And finally, we'd say, is this the right treatment? If you need a treatment to focus on symptom control, we can arrange that.
Okay, and I guess we have we use two basic strategies when a client is engaging in self-mutilating behavior. The first is to take the specific incident we'll ask them to describe a particular incident during the week where they did, let's say, cut themselves. And I'll try to figure out what was happening just before it and what triggered the particular desire to self-mutilate. And often we do this through imagery, by having the patient close their eyes and picture themselves leading up to the point where they cut themselves or did something to themselves. And then we figure out, through the imagery, what mode they were in when they did it. Were they, for example, in the abandoned child mode, feeling very isolated and alone? If that's what it ends up being, then the strategy we're going to be helping them to do is to learn how to reach out to people to not be alone, because being alone is the trigger for the self-mutilation. If, on the other hand, they're doing it to punish themselves, which is a totally different reason, then we have to work on the punitive parent mode, as we call it, and work with them to fight the part of themselves that feels that they're bad, terrible, and they deserve to be punished. And the third is they can't stand the overwhelming affect, and they're trying to get rid of it by cutting. And then we have to supply alternative ways to handle the affect other than cutting themselves. So part one is finding out what the mode is that led to the cutting, and then giving strategies, not skills, but real life strategies for learning how to deal with those feelings before cutting themselves. The other thing we're doing, though, which Frank made reference to, is we do ask them to agree to call us before they do it. That if they feel that they're going to cut themselves or do something to hurt themselves, including suicide as well, that they make a contract. The contract's not to do it, because borderline patients can't really make that contract, but to make a contract that they will call us before doing it. Most borderline patients experience that as caring, that you're willing to do that, and they'll wait, in fact, until they reach you, rather than cutting themselves most of the time. Because the most common cause of the cutting is feeling isolated, alone, and knowing that if they can connect with you, the therapist, in a reparenting way, they don't cut. And almost always, if we can get them to call us before they actually do it, and then we can go through the mode work with them, and through the relationship and the mode work, the self-mutilation gradually goes away, and in fact, very quickly goes away.
Well, I think that the short answer to your question, Ken, is that that's the essence of the treatment, is that we're trying to do a chain analysis, which bears some resemblance to what Jeff is saying in terms of moment by moment looking at the process from the point at which the person was not dysregulated to the point to which the person was dysregulated, and then cut. And we would do this not so much through imagery, but through good sort of cognitive strategies for how do you actually reconstruct events and have the most accurate memory. And if we're early in treatment, part of the purpose of doing that would be actually to help the person to learn what to pay attention to this week, because they probably missed something last week. So there's an intervention built into the assessment. And we know from cognitive science that, you know, what you rehearse is what you do. And so we get people to learn to discriminate. It's a learning treatment, so they're learning to discriminate the environment. You know, there are a million things, many millions of things going on at this very moment for all of us, and we're paying attention to some and not most. And if we're missing something important, okay, like, sorry, but if somebody, you know, if you left your stove on, you know, now would be a good time to remember that. Okay, you weren't paying attention to it. Okay, now would be a good time to remember that. And so if you're blithely going through your life and not aware that your emotion is going through the roof, it'd be good to learn how to notice that. And so we're going to teach you. Those are called mindfulness skills and emotion regulation skills. So we're going to do the chain and reconstruct what happened in order for the person to have some new skill that they can do next time when they're in similar situations. And that skill might be as simple as noticing it. Maybe I can't control it, but at least I'm aware of it. I now figured out what my primary emotion was. I missed it completely last time. Or maybe now that I know what it is, I can do something differently about it. And the whole session will be built around this. Now, Frank raised an interesting thing. He was making, I think you're making the assumption that it might have had something to do with you. We wouldn't make that assumption. We would, if it showed up on the chain, if something I did showed up on the chain, and from time to time it does, then it would be very relevant. But if it doesn't show up on the chain, we wouldn't assume that. And that's a huge difference, I think, between DBT and both TFP and schema-focused therapy, is that we don't use these underlying hypothetical constructs as illuminating. We just don't use them. So we're looking for how people make sense of their world, but it's how they really make sense of it. It's not necessarily that there is a right way to make sense of that.
Can I respond?
Let me just extend it, and then you'll have both a chance to reply. Sure, because
The phone call thing, I just want to correct. Frank said that DBT and schema focus would encourage phone calls. That's not quite right. We would encourage phone calls if that's what we need to do to generalize the skill to that situation. But actually, we wouldn't encourage it otherwise. It's about generalization of skills. It's not about phone calls, per se. Phone calls are neither good nor bad in DBT. They're one way to generalize, and actually a less preferred way because it intrudes on the therapist. So it's not that we wouldn't, we do, but we would prefer to have people fully empowered and able to do it without us. And that's a little bit different.
So you can reply, but it also just adds slightly, perhaps, so that the patient has been admitted to the hospital for an actual overdose that was, and then this is the first post-hospital appointment. So you can respond to anything that anybody had said about dealing with the inter-therapy cutting behavior, and then elaborate, or would you do anything differently in that post-hospital first appointment? I'll give either one of them.
Well, should we go the same order? Okay. So the idea now is the person's been hospitalized for serious self-destructive. Is that? Yeah. Okay. First of all, just to follow up on what Alan said, we would enter into other hypotheses that it might have to do with us, but certainly, we don't think we're the center of every action that the patient makes. Now, the hospitalization issue is a very important one, and the serious self-destructive acting out issue is important because it could be for so many different reasons. First of all, you'd have to sort of think in terms of differential diagnosis. Is the patient having a major depressive episode? If that's the case, then it's a different ball game. We have to treat it as such with medication and hospitalization if necessary. And if it's not part of a major depressive episode, if it's what we call a characterological depression, or it might not be depression, it might be anger that leads to the self-destructive acting out. We want to see what led to that. It could be any number of things. But I'll be a little provocative because I'll go to the subtype that I think the other two wouldn't be as likely to consider. A lot of times when our patients injure themselves, make a suicide attempt, go to the hospital, it turns out that we see it in terms not only of, being desperate or depressed or angry, but as doing something, to use a really provocative word, sadistic. We feel that's sadistic to themselves, and we feel it can be sadistic to others. I mean, a patient of mine who checked into a hotel room under an assumed name called her prior therapist, that's why she was referred to me at the time, called her prior therapist, called her husband, thank you so much, it's been wonderful, everything you've done for me, it just isn't enough, am I taking this huge overdose, which she did, and then luckily survived. So I think in a suicide attempt like that, there's aggression towards self and aggression towards others. So in that case, what helped, specifically in that case, was to get the patient to see, look, I know you're feeling desperate, I know you're feeling like you're overwhelmed, but I think we have to look at who's doing what to whom, and you're doing something to yourself. You're enacting two roles. You're the victim and you're the perpetrator of the aggression. And unless you get aware of both, you're just going to continue this stuff. And I know that you can't do that. That's from one case. But after yelling at me that I was saying she was a horrible person by saying that there was something sadistic about her actions, she calmed down, thought about it. I said, look, sadism, you don't have a monopoly on it. I have mine, you have yours, everybody has theirs. And once she could sort of own that part of herself that she only acted out until then, she really got beyond it and stopped doing that kind of behaviors.
Well, we wouldn't see it, of course, in schema therapy as sadistic. We wouldn't believe in the concept of sadism in BPD in general. We do believe in being self-punitive because borderline patients are often angry at themselves and they sometimes feel they deserve to be punished. But we don't consider that sadism. We consider that a feeling that they were bad and that they then want to basically punish themselves for being bad. And that to us is not the same as sadism. But now going to the question you asked, Ken, first of all, a tiny, tiny number of our patients have ever been hospitalized. Either at our center, in my own practice, or at the Dutch study. It's an extraordinarily low number. I've only had one patient in all the years who's ever been hospitalized. At our center, maybe there have been one or two. So, I mean, it's a tiny number. Now, the question is, why is the number so small? Because we tell all of our therapists, if you're ever unsure if a patient can make it to the next appointment, if you doubt it, have them go to a hospital where they're safe. But what we discovered is, back to the reparenting, if a borderline patient has access to somebody that they feel cares about them and is really connected to them, they don't make the suicide attempt. And even if they do something that's self-harming, it's not of the magnitude that requires hospitalization. So it's hard to convey, except through our outcome data now, happily, it's hard to convey how powerful the reparenting is in terms of reducing all of the acting out behavior. That's what stabilizes the patient, not the skills that we're teaching them, although we do teach them, again, strategies for each mode. But what stops the hospitalizations is they always have someone they can turn to. And if they know there's someone they can turn to, they'll wait until they can reach you, if they know you'll call them back. So it's that availability of contact. Now, as the therapy progresses, their need for that goes down because they get healthier. It's like a child. The more reparenting they get, the more nurturing they get, the more stable they are. The less they need you to be a parent. They start at 3 years old, then they're 5 years old, then they're 8 years old, then they're 12 years old, and they grow they developmentally during the course of the treatment. So the need for us to call them on the phone or to do these kinds of reparenting things goes down as the therapy progresses and the patient gets healthier. So we have the notion that in the early stages, the patient is emotionally very, very young and needs the same kinds of strategies you would use with a young child. But as they get healthier, you use strategies more and more appropriate for somebody older. But you're matching the intervention to the emotional age of the patient.
I think the short answer to your question, Ken, is that we would handle it in the same way that I've said before. Really, it wouldn't be any different. So I'm not quite sure what to add to that, other than, again, the idea is that if it was if it required hospitalization or emergency room treatment, it would be that much higher in the hierarchy. We would probably spend more time on it. because it's more dangerous, but not necessarily more time. It might get solved rather quickly. So I don't think we would handle that much the same. Again, we have to do a step-by-step understanding of how the person got there and make sure that they have a solution that's different the next time that they're on that chain. Just to highlight a little bit of a difference, I think, is also just in terms of our focus. Jeff, I think you see folks, even adults, as emotionally as very young. You say
at the beginning of treatment.
At the beginning, yeah, sure. And in DBT, we see adults as adults, and I think that's a profound difference. And I think, Frank, you and I have talked about this before, but I think also one of the things is that your treatment does look for aggression as a kind of key central point. And in DBT, we see that sometimes, but we also see a tremendous amount of other very intense negative emotions, lots of shame, lots of sadness, lots of fear, in particular shame as a secondary emotion. And so suicide attempts, at least statistically speaking, are linked to intense experiences of shame. So we're certainly, I think, looking for different kinds of things on the chain.
Can I ask a question along these lines? Because it will raise a much greater issue, broader issue.
Let me just say,
promise you.
Let me just say my
sure,
dilemma.
go ahead,
I have two things. The first thing is addressing the issue of the parent-child match or the infant-child match, which I think is very, very important. I want to do that. I also want, and I have 7 minutes, and I need to say a couple of things at the end. So I'll see how much I can behaviorally control the three of you, which is probably not going to be very good.
Just the hug would be good.
All right. And then and to give Frank the opportunity, at least, because there have been a number of cards about the dropout rates and the Geese study. But so let me frame the family issue in this way, and I think it's good. But I'm going to ask people to maybe try and answer in 90 seconds. Think of this as a democratic debate, but try and answer the question at the same time in the 90 seconds rather than avoid it. So how does TFP teach patients to respond to external cues or to cues effectively when childhood cues have been misread? So I'm directing that to this issue of the parent-child match. So that is, when one thinks about a failure of the parent-child match, one can think about it as invalidation. One can think about it as a child that's more difficult to soothe. It may be that a child's more difficult to soothe, and then a parent who can't resonate on the levels in which the child needs to be soothed. So some of what Marsha calls the biosocial, that there's an individual, an infant at least, with a certain constitutional predisposition that may or may not allow them to be receptive to environmental attempts to deal with their emotions, and an environment, everybody's human, that has limited or better or less capacities to respond to the match that happens to be your infant. 90 seconds each.
Sure. I think the idea, of course, is that this would show up in a context, first of all. It would show up, we'd be talking about it for a particular reason, because the person had a particular response that then was problematic and led to a conflict in a relationship, or it led to some kind of emotional pain, whether in stage 1 that's related to out-of-control things, or later on. We don't just stop with behavioral self-control. That's just the beginning. There's a lot more that happens. So it would be in a context, and we try to understand that. And then, of course, the idea would be to go back and go over what the person's responses were and try to understand what was missed. The idea that the dialectic, if you will, is that there's always something else that's there. There's always something else one can pay attention to. The question is, what would that get you? What would that add to your experience? And often what's missing, if there's been a mismatch, is the possibility of discriminating that a new person might have different intentions or have different, different emotions associated with that behavior, and to be able for, if I'm the patient, to learn how to discriminate how the fact that you smiled and said something, and it's like somebody else has done 1,000 times, but it was meant in a mean way, maybe you meant it in a loving, teasing way. And to tease that apart, to discriminate the differences, and how could I tell? So we would use, again, all the skills of DBT, especially mindfulness, but also some what we call relationship mindfulness, which actually looks a lot like mentalization, by the way, in some important ways, to slow that down and have the person look at what was missed and re-experience what was missed and see where that takes them. And so the therapist then, of course, would validate all those valid things along the way.
I want to go to Jeff first.
Yeah. Well, I think it's sort of is the two-part question. One is what is the role of the early? What's the interaction between the early parenting and the biological?
So are
makeup?
we thinking, when we think about early childhood, is this dysfunctional parents? Is this dysfunctional infants? Is this a question of match? What's the role of constitutional predisposition?
Well, I think that. Well, I want to compare it to DBT because it's a good comparison because both schema therapy and DBT agree, and I think TFP also, that it's clearly some combination of innate temperament with family and peer influences. And I also don't want to minimize peer influences because they also play a very big role. But I'd just say we differ perhaps in that I think that the role of the family is more major as a cause or origin of DBT than is the biological temperament. And I think you have some parents who just don't know how to deal with a highly emotional child, and they end up becoming frustrated, punitive, invalidating, and always with good intentions, but they don't know how to handle it, and they end up doing something that either punishes or somehow hurts the child. There are other parents who aren't great parents to begin with, meaning they don't hold their children, they don't pay a lot of attention to their children, some of them sexually abuse their children, and with these parents, the patient is in no way responsible for what happened. However, it may well be that the BPD patient reacts more negatively to bad parenting because of their emotional makeup. So I think you have to consider the two kinds of temperamental aspects. One is how does the parent deal with the child with that emotional temperament. The other is how does a temperamental child deal with a parent who doesn't know how to parent. And I think they're two different aspects.
Frank, could you briefly answer that and then talk about... No, it's really 11:30. We're into somebody else's time.
Yeah.
If you want to respond to that, and then I'll give you 90 seconds on the dropout rate or the Geese and Booth study.
Do I have 90 seconds on this question first?
Just talk fast.
Okay. My 90 seconds on this issue about, the ideology, if you want to call it that. Sure, we all believe temperament and environment to differing degrees. I think, just to speed up things, what the psychodynamic approach would add is how the experience is processed. I think we put more emphasis on internal fantasy life and how experiences can be exaggerated because of deep feelings and how experiences can be sort of misperceived so that a situation that might be unfortunate becomes disastrous, so on and so forth. And the one thing I'd want to emphasize about how this turns up later on, and I think this is a difference, we feel that if you are in a relationship that has a negative tone to it, you internalize both your part of it and the other part of it. And I said that earlier. So we would expect that later on the person experiences themselves not only as the victim in relation to a persecutor whom you may not be, but they also play the other way around. It's what in psychoanalytic terms is called identification with the aggressor, which is usually unconscious, and it helps to bring it to consciousness. In terms of the dropout study, since I was a consultant to that Dutch study, there are a couple of things. First of all, since we're all scientists, we have to agree that one study is great, but every study needs replication. And then in terms of the results, you have to realize that the results that were reported were about the intent to treat groups. In other words, all the patients who started the treatment, whether or not they finished. And since there was a high dropout rate from the TFP group in relation to the schema group, a lot of the patients whose results were included didn't actually get the treatment. So I think that has to be factored, because in a preliminary report, it showed that when they did what's called the completer analysis, which is usually done, it showed there weren't any differences, at least no significant differences, in those patients who got a full dose of each treatment. And I think it also is an issue of how you want to use psychotherapy research. I think it's better to use it to learn from than to see it as a horse race. So when I saw this data, I was particularly impressed with the schema group's low 7% dropout rate in the first year. Nobody's ever reported anything near that before. I think the TFP group at that point in that study was 23 or 4%. So I say, let's see what we can learn about patient retention. I can also add, as the person who is trying to teach TFP to the group there, I think the problem with retention rate was that they didn't quite get the subtleties of the treatment contract. It has to be done with a flexibility. They did it with a kind of a rigid take it or leave it attitude, and that's something I think that can be corrected.
Do I get a response to that? Yeah. Well, just a quick thing about this study, and I don't mean to be hard on Frank at all, but Arno has done Arno Arntz, who's the primary investigator, has done some follow-up studies related to this issue of were the therapists competent. I don't know if you've seen this yet. Unfortunately, what happened is he compared the outcomes of patients who were rated as highly competent by Frank and his group, and the ones who were rated low in competence. And the ones who were rated low in competence did better than the patients with therapists who were rated high in competence. So the argument that it was how well they did the therapy that determined the outcome seems to be exactly the opposite. The worse they were at TFP, the better the outcomes of the patients were. And it's quite dramatic. It's not like a tiny little difference. It's a very dramatic difference. So it is important to look at that.
Yeah, I have to speak to that.
I know you do.
Yeah.
And that's it.
And no. I think this requires really looking at the details, looking at how adherence was measured, looking at the number of letters I sent to the principal investigator over the years expressing concern about how the group was doing that didn't get any response. So there's a lot more to be said about it.
We really do need to stop. I'm the editor of a thing called with a scientific website, so I'm going to maybe invite these folks to begin a dialogue on that website, and maybe we can see where it goes. First of all, I intentionally tried to look at where the seams didn't exist, but I also want to put this maybe in context to where I began the morning, which has to do with there's some comfort to the idea that these are therapies that each in their own way and in some trials have been shown to be effective. They may have different endpoints in their effectiveness, and what we as researchers and people interested in moving the field forward is to try and find out what are the critical elements to these treatments. And I know the DBT folks are really trying to work at that. And can we streamline them to make sure that people get delivered what the essence of it is? And are there other stuff that's fluff that may not need to be delivered? And I don't mean fluff in any way that's kind of denigrating to any of the treatments. But there will be more studies. People continue to work at these things. Clearly, the people who invested in each one of these treatments listens to each other. You can tell that these folks were listening and didn't get too defensive, I think, so that we continue to move forward. But there does seem to be certainly hope that as we continue that these therapies can work, maybe not in everybody and not all the time, and as we continue to kind of explore them and refine them, that the prognosis for the therapy and for the someone wrote about clients, consumers, or patients. I'm a physician. I went to medical school. I use the word patients. That's not denigrating. I use that to people who have an ear infection or people who have schizophrenia. But that all depends upon essentially how you were raised, which maybe is one of the issues we're talking about here this morning anyway. But in general, that the future is hopefully not as dark as what one might, on a cursory view of the field, assume. Don't go anywhere. There's more to come. Alan?